So today we will assess the abdomen. So first is the inspection. So we will observe the coloration of the skin. The abdominal skin may be paler than the general skin tone. And then note for the vascularity of the abdominal skin. Scattered fine veins may be visible, and not any striae or stretch marks due to past stretching of the reticular skin layers due to fast or prolonged stretching. And next is to inspect for the scars and also assess for lesions and rashes. And then we also inspect for the umbilicus and note the color of the umbilical area, and the umbilical skin tones are similar to surrounding of the abdominal area surrounding the but abdominal area, and observe umbilical location, and the umbilicus is midline at the lateral line. And then also assess the contour of the umbilicus, and it is inverted or protruding to more than 0.5 no more than 0.5 centimeter, and is rounded or conical. So next is inspect the abdominal contour. So while sitting at a client's side, look across the abdomen at the level slightly higher than the client's abdomen, and inspect for a that area between the lower ribs and the pubic bone. And next is we will assess the abdomen symmetry. So the abdomen is symmetric, and observe the aortic pulsations. A slight pulsation of the abdominal aorta, which is visible in the epigastrium. And observe the for the peristaltic waves. And normally peristaltic waves are not seen, although they may be visible in very thin people as slight ripples on the abdominal wall. So next is for the auscultation. So we will auscultate for the bowel sounds. So we will use the diaphragm of the stethoscope, and we will begin at the right lower quadrant and proceed clockwise, covering all the quadrants. And note for the density, pitch, and strength of the sound. So and then we will auscultate for the vascular sound. So we will use the bell of the stethoscope to listen for bruits over the abdominal aorta. The renal, to the iliac, and femoral arteries. So it is not normally heard. So next is listen for venous hum using the bell of the stethoscope. Listen for the venous and epigastric and umbilical area. And I will auscultate for a friction rub over the liver and spleen. So listen over the right and left lower rib cage with the diaphragm of the stethoscope. So no friction rub over liver or no spleen is present. So next is the percussion. We will percuss for tone. So we will lightly and systematically percuss the all quadrants. So we'll start here. So the dullness is here over the liver and spleen. So next we will percuss the span or height of the liver by determining its lower and the upper borders. So to assess the lower borders, so we will begin at the right lower quadrant at the midclavicular line and percuss upward. So we will note the change from tympany to dullness. So we will mark this point, so it is the lower border of the liver dullness. And next is to assess the upper borders, so we will percuss over the upper right chest at the midclavicular line and percuss downward. So we will note for the change from the lung resonance. From the lung resonance to liver dullness. And we will mark this point. So it is the upper border of the liver dullness. So it is located at the left between the 5th, 7th intercostal spaces. So we will next we will measure the distance between the two marks. So the normal liver span at the midclavicular is 6 to 12 centimeters. So its span is 6 centimeters. Next is we will repeat the percussion of the liver at the midsternal line. Measure. So the normal span at the normal liver span at the midsternal line is 48 centimeters. So its span is 4 centimeters. So it is normal. So next is to percuss the spleen. So begin with the posterior to the left medaxillary line. So we will percuss downward. And we'll noting the change from the lung resonance to the splenic dullness. And next is the second method of detecting the splenic enlargement is to percuss the last left anterior space at the anterior axillary. So while the client takes a deep breath, so hinga ng malalim. So normally, tympani or resonance is heard at the last left interspace. So next is to perform the blunt percussion on the liver and the kidneys. So we will percuss the liver by placing our left hand flat against the lower right rib cage. And we will use the other side of our right fist to strike you to strike our left hand. So we will perform the blunt percussion on the kidneys. So normally no tenderness is elicited. So we'll perform the blunt percussion on the kidneys at the cosvertebral angles over the 12 ribs. So no tenderness or pain is reported by the client, and the examiner senses only a dull thud. So next is the palpation. So we'll perform light palpation. So we will using the fingertips. So we will begin the palpation in the non-tender quadrant and compress depth of 1 centimeter in a dipping motion. Then gently lift the fingers and move next area. And the abdomen is non-tender and soft. So next we will deeply palpate all quadrants to delineate abdominal organs and detect subtle masses. So using the palmar surface of the fingers, compress the maximum depth of 5 to 6 centimeter and perform bimanual palpation if you encounter resistance or to assist the perstruction. So next is we will palpate for the masses. So note their location, size, shape, consistency, their marcation, pulsatility, tenderness, and mobility. And no palpable masses are present. So next we will palpate the umbilicus and the surrounding area for swellings, bulges, or masses. So next we will palpate the aorta, then assess the patient pulsation of the abdominal aorta, and the aorta is approximately 2.5 to 3 cm wide with a moderately strong and regular pulse. And next we will palpate for the liver. So we'll palpate it bimanually. So we'll ask the patient to inhale. Inhale, please. Then compress upward and inward with the fingertips. And then it should be firm, smooth, and even. So next we will palpate by hooking. So hook the fingers of both hands over the edge of the right costal margin. Then pull inward and upward with your fingers. And so next we will palpate for the spleen. Then ask the patient to inhale and press inward and upward. You provide support with your other hand. And the spleen is seldom palpable at the left costal margin, so it should be soft and non-tender. So alternatively, ask the patient to turn into the right side. Turn to the side, please. Ano ka dito? Then, palpate the Side lang. That. Thank you. Then, palpation. We have to palpate by moving downward and forward and document the size, note, consistency, and tenderness. So next, palpate the kidneys. So the kidneys are usually not palpable. So if palpated, it should feel firm, smooth, and rounded. So to capture the kidneys, we ask the patient to inhale. Then compress. We compress the fingers deeply. And then to palpate the other side of the kidney, so we will reverse the procedure. So next we will palpate the urinary bladder. So an empty bladder is neither palpable nor tender. So next we will perform the fluid wave test. Pwede ilagay ang kamay. Push. So no fluid wave is transmitted. So and next we will assess the rebound tenderness. So we will palpate deeply at 90 degrees into the abdomen away from the painful or tender area. Then suddenly release pressure. Then listen and watch for the client's expression of pain. Then ask the patient to describe which hurt more, the pressing in or releasing, and where on the abdomen have the pain occurred. So it is no rebound tenderness is present. And next is we will test for referred rebound tenderness. So we will palpate deeply in the left lower quadrant and quickly release pressure, and no rebound pain is elicited. So next we will assess for psoas signs. So we'll ask the patient to lie on the left side. So tagilid lang. Tagilid po. And hyperextend the right leg of the client. And then no abdominal pain is present. So next we will assess for the obturator side. So back ma'am. And support the right client's knee and the ankle. Flex hip and the knee. And rotate the leg internally and externally. And no abdominal pain is present. So next we will perform hypersensitivity test. So we will stroke the abdomen and grasp a fold of skin using our thumb and index finger and quickly let go. And do this several times along the abdominal wall. And the client feels no pain and no exaggerated sensation. And next, we will test for cholecystititis. Then we'll assess the right umbilical quadrant pain or tenderness, which may signal cholecystitis. And we will press our fingertips under the liver border at the right costal margin and ask the patient to inhale deeply. Inhale, please. And no increase in pain is present.